acute infection. So this time, let's discuss chronic osteomyelitis. And so chronic osteomyelitis, you all know, it is a presence of a residual focus of necrotic bone or soft tissue, which then acts like a nidus and which then gives rise to recurrent flare-ups of clinical infection. So you can have periods of exacerbation and remission in chronic osteomyelitis. Now, because it is an extension of acute osteomyelitis, it is sequel of acute osteomyelitis, it is obvious that the bacteriology is almost the same as acute osteomyelitis. So mainly you see Staph aureus and MRSA, but in cases where you have a prolonged discharging sinus, what happens is there can be secondary contamination, and many times this secondary contamination is by gram-negative organisms. So many times you can also see mixed bacteriology within a chronic osteomyelitis. So that is where it is slightly different from acute osteomyelitis in terms of bacteriology. Now, coming to features, there is no real, demarcation that has been mentioned. Okay, if it is more than 3 months, you should call it chronic osteomyelitis. No such clear demarcation in literature. But what you need to understand that, chronic osteomyelitis is not just simply an acute osteomyelitis, which is prolonged in duration. Okay, there is some specific, problems, specific pathological features of chronic osteomyelitis, which make it more difficult to treat. And the most important what you have to understand is systemic antibiotics, which you use in acute osteomyelitis, are not effective in chronic osteomyelitis. So with that, let's try to understand that why is chronic osteomyelitis such a difficult entity to treat. I warn you that the initial part of this presentation there is going to be a lot of theory, but I shall try to cover it up by showing you a few case examples at the end. So please bear with me. So there are three main pathological processes that you should be aware of. Number one is formation of sequestrum. Then the host response, which gives rise to the formation of the involucrum. And finally, I think the most important is you have to understand what is a biofilm and why the biofilm makes chronic osteomyelitis such a difficult condition to treat. So coming to sequestrum, I'm sure you all know about how a sequestrum is formed. So in acute osteomyelitis, there is an initial focus, most commonly in the metaphysis. This leads to increased intramedullary pressure. Once the pressure exceeds a certain point, the exudate of this infection, it perforates to the cortex. This leads to elevation of the periosteum and formation of subperiosteal abscess. Now, because the periosteum is lifted off, the blood vessels which pass from the cambium layer of the periosteum to the bone, to the cortical surface of the bone, they are disrupted. So there is a loss of periosteal blood supply. And already, the endosteal blood supply is already damaged because of the intramedullary infection. Now, additionally, the periosteal blood supply is also affected because of lifting off of the periosteum. And that's what leads to bone necrosis. And that necrotic fragment of bone is called a sequestrum. So you have to be very clear about why a sequestrum is formed. That is something that can be asked to you in the exam. All sequestrums are not alike. Okay, there are different varieties of sequestrum. So you have to understand that sequestra can either be focal or segmental. So here is an example of a focal sequestrum. By focal, I mean that the entire circumference of the bone has not become necrotic. Only a part of the cortex has become necrotic. And focal sequestrum that way are good because removal of these don't lead to structural instability. On the other hand, there are segmental sequestra, which this picture is self-explanatory. What is a segmental sequestra? The entire circumference of the bone is affected, and removal of these sequestra leads to significant structural instability, which then needs complex reconstructive procedures. So that's the difference between a focal or segmental sequestra. Also, you have to understand that the natural history of all sequestra is not the same. Most commonly, you have a situation where a sequestra leads to persistent infection. So the sequestrum stays there and it gives rise to recurrent attacks of clinical infection. That it's the most common scenario we see. And unless that sequestrum is taken out, the infection does not subside. So that's the most common scenario we see. But we may occasionally also see scenarios where the sequestrum is either partially or completely resolved as a result of the action taken by the host immune system, or you may even have situations where the sequestra gets gradually revascularized and it actually incorporates into the involucrum. So these are sequestra, the rare situations where removal of sequestrum is not needed. But the partially or completely resolved, that can lead to resorption can lead to structural instability, and here is an example of this. So here what has happened is the involucrum has failed to form. The host immune system has launched an attack on the sequestrum. Therefore, the sequestrum has almost been completely resolved. Just a bit of a faint of a strand you can see over here. That is probably the residue of the old sequestra. But so here what happens is that by the time the patient presents to you, the infection has already settled, but because there is resorption of the sequestrum, it has lead to a structural instability which then needs reconstruction. So that's about the sequestrum. Involucrum, again, you are all aware as to how an involucrum is formed. Because that cambium layer of the periosteum, it is lifted off the bone. Therefore, then it gets stimulated within the cambium layer. You are all aware there are osteoprogenitor cells which then generate new bone, which forms the involucrum and which tries to provide stability. So if the involucrum is well formed, then it provides structural stability and you don't need to reconstructive procedures. However, if the involucrum fails to form appropriately, or if even that involucrum and periosteum is destroyed by infection, then it leads to structural instability. Then we come to probably the most important part of the pathology of chronic osteomyelitis, and that is biofilm. So please understand what is a biofilm. So it is an extracellular polymeric substance which is secreted by the bacterial cells themselves. And then this polymeric substance just walls off or encloses the bacterial cells. And then what it does is this biofilm, it searches and adheres to an inert surface, that is a dead surface. And most commonly in the situation of chronic osteomyelitis, this inert surface is either the sequestrum, or in post-operative cases, it is the implant. And this biofilm is the main reason why antibiotics don't act. Let's try to understand why the biofilm, how the biofilm protects the bacterial cells. So number one is it acts like a kind of a physical barrier itself, which the antibiotics as well as the host immune cells find difficult to penetrate. So that's the first mechanism of action. Second mechanism, within the biofilm, it creates local hypoxia and acidic pH, again, which are not favorable conditions for antibiotics or host immune cells to act. So that is the second mechanism of action, how a biofilm acts. And thirdly, within the biofilm, the bacteria themselves, they undergo some transformations. So number one is the bacteria convert into what is known as persister cells. So persister cells are, bacteria with very low oxygen and oxygen demand and metabolic activity, and therefore these cells are highly resistant to action by antibiotics. Secondly, sometimes what happens is this bacteria transform themselves into something called as small colony variants, and these small colony variants, what they do is they penetrate the host cells themselves, so that they may penetrate the osteoblasts, the osteocytes, and within the cells, these it becomes very difficult for the antibiotics to penetrate the host cells themselves and to kill them. So these are some of the mechanisms how a biofilm acts. What is most important to understand is that very high concentration of antibiotic is needed to kill bacteria within a biofilm. So if the bacteria are free, that is, these are called the planktonic bacteria, which we see in acute osteomyelitis. Suppose the antibiotic concentration that is needed is 1 MIC. Then on the other hand, if the same bacteria, they are within a biofilm, then you require a concentration of antibiotic almost 100 to 1000x. And this level of antibiotic concentration is not achievable with systemic antibiotics because that can lead to systemic toxicity. Okay, so IV antibiotics are not effective, or systemic antibiotics are not effective in chronic osteomyelitis. And what is needed over here is local high dose antibiotic delivery, which we will see soon in the section of management, which forms an integral part of management of chronic osteomyelitis. Next, we come to classification. And in classification, the most popular classification that is used now is something known as the beat cure classification. Uh, so it's a very simple classification to understand, and it's useful to know because it gives you some algorithm for management. So within the beat cure classification, type A is Brody's abscess, which we all know is a lytic cavity within the bone. There is no sequestrum here. The walls may be sclerotic. So that is type A beat cure chronic osteomyelitis. Type B are chronic osteomyelitis with sequestrum, and these are again subclassified into B1, B2, B3, B4. So B1 is a cortical sequestrum, no significant involucrum, but it does not cause any structural instability. So this is an example, B1. So this is a cortical sequestrum. In fact, it is extracortical. B2 is the sequestrum is present within the involucrum, and this involucrum is normal. It is a structural normal involucrum. So that is type B2. B3, again, there is a sequestrum which is present. Additionally, the involucrum is sclerotic. Okay, so you can see there is a sclerotic wall which is around this sequestrum. So that is type B3. And type B4 is, where the sequestrum is present, there is a non-structural involucrum, and removal of this sequestrum is going to lead to a gap, which we will need to secondarily reconstruct. So that is type B, that is, chronic osteomyelitis with sequestrum. And there is a fourth type, that is type C, in which there is no sequestrum, but the canal is highly sclerotic. And in these cases, it is necessary to ream the canal, which we will just see in the management section. So this is the bed cure classification. Type A is Brody's abscess. Type B is sequestrum, where for type B4 is the one with unstable sequestrum, and type C is sclerotic medullary canal. The other classification that is described is Penny's classification, and it in fact covers almost all the types which are described in bed cure classification as well. But there is this type, type 2 atrophic, which is not really, mentioned in the bed cure classification. And so this type is, if you're using the bed cure classification, be aware that this type is not included in that. And we do see cases of this nature. I will show you in the case example as well, where we often get an atrophic chronic osteomyelitis where the the periosteum has already died, there is no involucrum, and even the sequestrum has got resolved. Now coming to the main part of this talk. So management, basically we are going to focus on surgical management, and in surgery there are four parts here. Okay, it is not just simply you go do an IND, drill holes and come out. There are four parts to successful surgical management of chronic osteomyelitis, of which the first and probably most important is surgical debridement. But along with that, equally important is high dose local antibiotic delivery, then dead space management, and finally reconstruction, which is needed for the type B4, beat cure type B4, which I mentioned, where there is a segmental sequestrum, and also for the atrophic type, that is the Penny's atrophic type. So for that, you require to additionally reconstruct that defect, right? So let's first talk about debridement. So some principles about debridement, before going in for surgical management of chronic osteomyelitis, I always prefer to get a preoperative MRI. Now, how does the MRI help you? The MRI helps you in understanding the true extent of the infection, because that is then dictates your surgical approach, how much you are going to open up, how much you are going to debride. The MRI tells me that. And also, some sequestra which may not be easily identifiable on the X-ray, they can be identified with the preoperative MRI. So I think before going in for a chronic osteomyelitis, a preoperative MRI is extremely important. Secondly, while doing a debridement of a sclerotic bone, I mentioned that the involucrum is very often sclerotic. So here you have to look what is the end point of your debridement. So you have to look for something known as paprika sign, which means punctate bleeding from the Haversian canal. So that is what you should look for at the end of your debridement. And so if that is present, you know that your bone is viable and you can stop at that. And last but not the least, you have to ream the proximal and distal medullary canal. So you have to connect the normal medullary canal with the osteomyelitic cavity. So you have to let the osteoprogenitor cells, flow from the normal proximal and distal medullary cavities into your osteomyelitic cavity. So these are some of the principles of the debridement. Additionally, the bait cure classification gives you some guide as to how your debridement is going to be. So in bait cure type A, you have to do a saucerization, which means simply you have to de-roof your abscess. And type A, remember, is the Brody's abscess, right? So you have to de-roof that abscess and you have to do curettage of the abscess cavity. That's number one. In beat cure type 1, 2, 3, 1, 2, 3, remember, is chronic osteomyelitis with sequestrum, but with structural involucrum. In these cases, you have to do saucerization and sequestrectomy. So you have to de-roof the cavity and also you have to remove the sequestrum. Type B4, you have to do saucerization, sequestrectomy, but additionally, you will need to do a stage reconstruction as well. We will come to the techniques of reconstruction in a short while. And finally, in type C, it is extremely important that you have to ream the entire medullary canal and drain whatever intramedullary abscess might be, that you have to do it. In atrophic type, many times these cases present to you after the infection has already burnt off, and here you are left to deal with the bone gap, which you should do with stage reconstruction, as we will soon see. Now, a few more tips regarding debridement, regarding saucerization particularly. So, as I mentioned, that you make a hole in the involucrum through which you take out the sequestrum. So, it is recommended that this saucerization that you do, the cortical window that you prepare, it should be oval rather than rectangular, because it is thought that the rectangular sharp edges, it makes the bone more prone to pathological fracture. So try to make your cortical window oval rather than rectangular. Number two is, if your cortical window is large, okay, and it involves more than 30% of the cortex diameter, then there is a very high risk that there is an impending pathological fracture. Remember that already this is weakened bone, and in these cases you should prophylactically stabilize, which in the case of an active infection is most commonly with an external fixator. So these are some of the principles of debridement. So debridement, as I mentioned, is the first arm of your surgical management. The second important arm is high dose local antibiotic delivery. As I mentioned, IV antibiotics don't work in chronic osteomyelitis. So you need to give a high dose local antibiotic delivery. And over here, there are the most popular or the most commonly used antibiotic delivery systems are our bone cement, that is polymethyl methacrylate, which is non-biodegradable, and there are calcium sulfate granules, that is stimulant we use most commonly, that is biodegradable, right? So these are the two that we use most commonly. So just let's look at each of these one by one and understand the pros and cons. First, coming to bone cement. So if you are using 40 grams of bone cement, how do you prepare your antibiotic cement mixture? So in this, what you have to do is you have to first take the cement powder and you have to add first your vancomycin powder to it. If you are using your antibiotic in the powder form, you should first mix your antibiotic powder to it. Now, this mixture, that is the cement plus the antibiotic powder, then you add your liquid monomer to this powder. And then if you are additionally are going to use a liquid antibiotic like say gentamicin, then once this mixture reaches the liquid phase, then you should add your gentamicin to it. Now these doses that I have mentioned, 2 to 4 grams for vancomycin and 240 milligram for gentamicin, these are actually doses mentioned for adults, and we don't really have any literature regarding what is the safe dosage for children. So that is something that we have to trade very carefully, consider, and we have to take into consideration the weight of the child, the size of the child, before deciding what dose of antibiotics we are going to add. Now, this slide is a bit theoretical, but please, it's pretty important to understand this. Now, understand that the elution of the antibiotics from the cement surface, okay, it is a surface phenomenon. So, therefore, only the antibiotic which is exposed to the surface or which communicates with the surface through small pores or cracks, that is eluted into the surgical site locally. Okay, but more than 50% of the antibiotic which is trapped within the core of the bead is never released. So that is one negative point of PMMA. Another negative point of PMMA is its bimodal elution. So what happens typically in PMMA is in the first 48 hours after the surgery, you get a burst phase where the local antibiotic concentration is very, very high. But this soon, tapers off and you get what is known as the tail phase, which lasts for several weeks. And at a certain point, what happens is that the local bacterial concentration falls below the MIC. And when that happens, if there are any bacteria still remaining at that point of time, then there is a tendency that these bacteria can mutate to a more resistant form. And that is the problem with PMMA. Therefore, if you are using PMMA, ideally you should never keep the spacer on for more than 4 weeks, because beyond 4 weeks, the cement spacer itself acts like an inert surface and your biofilm can come and adhere to the cement block. So you started off with a sequestrectomy, but now your cement block itself acts like a kind of a sequestrum or an inert surface which promotes the adherence of biofilm. So never keep a cement more than 4 weeks. Also, there are thermal constraints to what antibiotics you can use. You can only use heat stable antibiotics like Vanco and Genta. So these are some of the negative points of PMMA. But having said that, the literature still has a very high success rate of PMMA, and almost 85 to 90% of the cases, the infection control is achieved only after one debridement. So the efficacy is still pretty high. And in cases where you need to do a stage reconstruction, where you anyways need to go in again to put a bone graft or anything, I think cement is the preferred option rather than calcium sulfate granules, because it also offers structural stability and it also leads to the formation of induced membrane, which we'll see in a short while. Next, the other carrier is calcium sulfate granules, and you again are well aware, we have done a few cases, quite a few cases over here. So this is a single stage procedure. The carrier elutes the antibiotic and then gets resolved within the body. It is biodegradable, right? So this is single stage. You don't need to go in again to remove calcium sulfate granules. And it fully resolves within 4 to 12 weeks by dissolution plus osteoclastic activity. Additionally, what happens is the calcium sulfate granules themselves are osteoconductive because they promote ingrowth of blood vessels and osteoprogenitor cells, and therefore they are osteoconductive, which is another plus point of calcium sulfate granules. Also, elution kinetics is much better than cement. You have 100% antibiotic release. You have a more uniform elution of than PMMA. So remember, in PMMA there was a burst phase and tail phase. That does not occur in calcium sulfate. Here, the antibiotics are eluted in a much more uniform manner, and more than good concentrations of local antibiotic are maintained for 30 to 40 days, and plus it allows mixing of heat labile antibiotics as well. Again, how do you prepare calcium sulfate antibiotic granules? So if it is a powder antibiotic, you have to mix the powder with stimulant powder and then add the kit water. However, if it is a liquid antibiotic, then you have to substitute your kit water with the liquid antibiotic. So in that case, you don't need to use the kit water. You can use liquid antibiotic. This is a PDF which is available on the Stimulant website itself, and it gives the range of antibiotics that you can use, and you can refer to this before you're going in for surgery. Calcium sulfate, it has a very good efficacy, in fact, even higher than cement. And the advantage, again, that there is no need for secondary procedures to remove the calcium sulfate. However, if you're going to need a secondary reconstructive procedure, then it does not offer that big an advantage. One problem with calcium sulfate granules you have to know is the formation of what is known as sterile seroma. Now, what happens is this calcium sulfate is hyperosmotic. It draws fluid into the implanted area, and then sometimes this fluid then oozes out of the surgical wound, and you may end up confusing this with pus. And it is important to differentiate this from a pus. So you should be aware that this phenomenon of sterile seroma exist in calcium sulfate granules, and not hurry to drain it thinking it to be pus. Now, what are the problems with both these systems? Number one is the risk of systemic and renal toxicity, especially in cases of younger children. That is the main problem that we face with both PMMA as well as calcium sulfate granules. And therefore, in small children, we have to be extra careful as to how much of the what is the dose of antibiotics that you are mixing with the cement or the calcium sulfate. Additionally, if you are giving the same antibiotics IV as well, then you have to take into account that both of them have a synergistic toxicity. Now, to counter that, okay, now this is the latest kid on the block that is called bioactive glass, and it is a non-active, non-antibiotic bactericidal. So what it does is bioactive glass, it releases locally sodium, calcium, phosphorus, and silicon ions, which creates a very strong alkaline pH locally, and the pathogenic organisms cannot survive within this alkaline pH. And secondly, it has a high osmotic activity, because of which the bacteria are dehydrated. It disrupts biofilms, and there is no risk of resistance, because this is not an antibiotic. It is a physical agent which kills the bacteria physically, and therefore there is no risk of resistance. And just like I mentioned in calcium sulfate, bioactive glass also has osteoconductive properties. So it can promote the formation of new bone where it is implanted. So it is also used as substitute for bone graft. Okay, so it has bactericidal properties as well as it is a bone graft substitute. The problem with bioactive glass is quite costly. It is even almost 3 times costlier than stimulant. It almost costs 75,000-80,000. So that's a real limiting factor to its use. The third wing is dead space management. And what happens is, if you leave a dead space, then that leads to accumulation of a hematoma, which again leads to is a culture medium for bacteria and can lead to reinfection. So how do you tackle the dead space? Number one, if the dead space is within the bone, then just pack that dead space with calcium sulfate antibiotic granules. Or if your infection is already controlled, then you can even pack that cavity with bone graft. On the other hand, if that dead space is within the soft tissue, then you may need to take the help of your plastic surgeon colleague and use some soft tissue flaps in order to cover up that dead space. The final part of the surgical management is reconstruction, and reconstruction is needed in cases where there is a segmental sequestrum, or cases which have come to you with an atrophic kind of chronic osteomyelitis. And therefore, here the main common techniques that we use is, number one, internal bone transport. What we are most fond of is the Mascali two-stage induced membrane technique, which I shall discuss in some detail. And finally, if the infection is again controlled, you can directly go for non-vascularized fibula graft. I shall describe the Mascali in a bit more detail. So Mascali, as you all know, it is a two-stage technique in which the first stage is debridement. Then you place the antibiotic cement spacer. And the important thing is that this spacer should overlap about 1 centimeter of the bone ends. So that is an important nuance of how do you place the cement spacer. So we commonly use this syringe, the slit syringe, in order to prepare the cement spacer. And so take the example of this case. So you can see that there is a gap about 3 to 4 centimeter between the two bone ends. So what we do is we take a 10 or 20 cc syringe, we cut off the flange as well as the nozzle, we slit the syringe longitudinally and then wrap it around the bone ends. So this is how it is done. And then we mix the cement, and then that cement is then the slit is opened within the syringe. The cement is then inserted into that syringe, and then we close that slit in order that the cement that then sets perfectly in that position, and it uh, achieves the shape of the bone. And this is after removal of that, that syringe wrapping around the spacer. This is how the spacer is formed, and you can see how uniformly the spacer is formed, and it overlaps 1 centimeter of the bone ends on each side. Then the second stage comes after around 4 to 6 weeks. And so what happens is, once you put this spacer, it induces a membrane is formed around it. And it is very interesting to note the histology of this induced membrane. So the inner layer of this induced membrane, it is a pseudosynovial layer containing synovial cells, macrophages, fibroblasts. So these all secrete, growth factors and bone morphogenic protein, which promotes the formation of new bone. The middle layer is a vascular layer which helps to revascularize the cancellous graft, which you are then going to place within that induced membrane tube. And the outer fibrous layer, it provides physical barrier and mechanical strength. So this is, the second stage surgery. You can see this is the cement spacer over there. And this over here that you can see on each side, that is the induced membrane. So the spacer is then taken out, and then this fibula is then interposed. Some cancellous graft is also placed, and then this induced membrane that is there, we then close it over the fibula graft to achieve reconstruction. So this is about the Mascale two-stage induced membrane technique. Now I shall end the talk with a few case examples. Now this was a case which came to us in the acute infective stage, but it was a very small sinus which used to, sporadically open up, drain a bit, then again close off. And if you see over here, this child already has a pathological fracture. Okay, can you? I hope you can appreciate. Plus, there is a sequestrum, and there are some cloacae within the involucrum. So what we decided is that since the infection was not florid, okay, there was a sinus which was draining, on and off. We decided to wait it out for some time and let the fracture probably heal, and let's see if it heals. And that's what happened. You can see now that in this, the fracture has completely healed. And now all we had to do is then treat the infection, which we did by removal of this sequestrum, and we implanted the calcium sulfate granules. Here we did granules rather than PMMA because in this case we didn't anticipate a second stage reconstruction. So we wanted to go for a one-stage procedure. That's why we implanted these granules. And sure enough, within a few months' time, this completely healed off. So this healed completely with a single stage surgery. So in cases where you don't anticipate secondary reconstruction, I think, PMMA, calcium sulfate granules is the preferred modality of high dose delivery system. Second case I will show now. Here again, this is a sequestrum, but you can see that the involucrum is not that healthy. If you remove this sequestrum, this is completely open over here. Okay. And here in this case, this was also presenting with a discharging sinus, as you can see over here. And this case, I will show you. This is the importance of the MRI. Just look at this transverse cut. There was a huge, collection on the posterior aspect as well. Okay, now how often during our surgery do we explore the posterior compartment of the thigh? So that's the importance of the MRI. Get a preoperative MRI. You will know where all your pus is tracking, and that helps you to plan your surgical drainage. So that's what we did. We opened up everything, we debrided everything, we cleared off the pus, went into the posterior compartment of the thigh, cleared that as well. And in this case, because there was a high chance of an impending pathological fracture, in addition to putting the stimulant, we applied an external fixator. But as you can see over here, now this is at the end of around, if I remember correctly, around 6 weeks. And now the stimulant has completely resolved. By this time, the infection had completely cleared. Okay. And this was around more than 10 years ago, around 12, 13 years ago. And what we did is, okay, this picture again, I would like to show you before proceeding further. This is a seroma. You can see over here. So this looks exactly like pus. And it is very important that at this stage, if I had mistaken this for a pus and had gone ahead and opened and debrided it, then all my, stimulant would have come out and, I would have unnecessarily done an additional procedure for this girl. So you have to understand that seroma, it resembles pus in all aspects. This lasted for a few days, immediately settled. And then, this was after about, say, 6 weeks or so. And at this time, we removed the fixator. As you can see over here, this still does not look too strong. So, probably if this case came to me today, I would have at this point of time probably added a prophylactic plate and maybe put a bone graft over here after control of the infection. But at that time, I just held on, and luckily for me, this did not fracture. This was, I think, at the end of around 1.5 year. So that was so. So here in this case, uh, uh, the takeaway points are, if there is a impending fracture, always stabilize with an external fixator. This case further, shows you the importance of prophylactic fixation. So similar case again, this was a discharging sinus. There was no clear sequestrum here, maybe a small one here, but this one debrided, and we failed to, we didn't, stabilize this with a fixator, and look what happened. This landed up with a pathological fracture. By this time, the infection had completely settled. So what it did is we just, put in a fixator and just, prayed that, it would heal just with this. This one would not need more complex reconstruction. And indeed, we were extremely lucky that it went on to heal without any problem. Next case I want to show now, this is what Penny described as the atrophic type. The infection has completely burnt out, the infection is healed, but now that sequestrum has completely resolved, and you are left with a large gap in the tibia over here. So here we went with the masculine two-stage reconstruction. Here you can see this is the cement spacer. So this is the first stage surgery. This is the second stage surgery where we put the fibula graft now. Yeah, this is the fibula graft. And this is after healing, the fibula graft has healed, and this is on further follow-up. So you can see now that the fibula graft has completely taken. It almost resembles a tibia, impossible to differentiate it from the tibia, but there is a deformity, plus there is a significant ligament discrepancy at this point of time. And therefore, about 3 to 4 years after this procedure, then we lengthen. Remember that this lengthening is through the fibula. It is not we are lengthening the tibia, it is lengthening through the implanted fibula. So this is lengthening of the fibula, the fixator, and this healed. And this was at follow-up. And this was the recent picture, the picture to the right. So from here, about 5 or 6, this is the Vaidya girl only. Some of you might have seen her on follow-up. So we have now reached here. But still, the reconstruction is not complete. As you can see, there is some proximal tibia, growth arrest. And that can, probably is going to, she already has some LLD, if you can see over here. So she is going to need some procedures ahead as well. But so this is, you have to follow this child. But can you believe that this is a fibula? This is not the tibia. So that's the beauty of, non-vascularized fibula in children. Last case I will show. This case again, some of you might have seen. I think Nandini assisted me for this case. So this case presented to me, was operated elsewhere and presented to me with an implant failure. And the history was that post-operative, this child had something like a compartment syndrome of the thigh, and the wound took a long time to heal. But yet, at this time, there were no local signs of infection, and I thought that, this is just a case of, implant failure. So we went in, what we did was we removed the plate, we bone grafted that site, and we fixed it with an interlock nail. Intraop, we didn't see any signs of, infection over there. And we sent deep cultures as well, but they also came out to be no growth. However, as luck would have it, she landed up with a post-operative infection. So you can see there is a discharging sinus here. And then gradually over a period of time, what happened is that the bone, progressively resorbed. And you can see that the bone has now resorbed. This was about, 2 months after my interlock surgery. And indeed, when I opened up this was done at Vaidya. You can see what has happened to the bone. The infection has completely eaten out the bone. This was the previous one, where at the time of my surgery, at the time of the interlock surgery, and then over here, complete erosion of the bone, and we had to do a complete, so we again, put in the cement spacer, stage 1 of the masculae. So this is the cement spacer that was put. This is the X-ray after the cement spacer. This is the second stage surgery. Now the cement spacer is come out, and here we put fibula. This is the fibula graft which we have put in that defect, and over that we put the cancellous graft. and this is how the fixation was. And she's almost now about 4 months post-op, but doing well now. The infection has completely settled, and the bone is healing pretty well. But she has a stiff knee, so still, a long way to go. So to conclude, remember the what is the pathophysiology of chronic osteomyelitis? It is sequestrum or implant plus biofilm, and that lethal combination makes IV antibiotics absolutely ineffective. Treatment should be a combination of debridement plus high dose local antibiotic delivery plus obliteration of dead space. And if at all there is a bone defect, then you probably need to reconstruct it, where mascale is, I think, a pretty useful technique and has proved very good in our hands. Thank you so much.
Very, very nice, comprehensive, and lucid lecture. So, only thing I want to add to you guys is that, see, judgment is very, very important here in all these cases, especially in chronic osteomyelitis. How much to take out, how much to retain, what implant to use, whether to span or no, how much to protect. So, all these things will come with time, but this is something which is going to be on a day-to-day basis for you all. So, it's absolutely imperative, number one, to get the acute infection correctly sorted. And then on top of that, when we are dealing with the chronic part, how complete your sequestrectomy is. I always tell you all, remember that whatever comes off easily, you must take out. And whatever is dead and dying on table, that you should know how much to take out. So debridement is a very, kind of basic but absolutely thorough kind of a thing that all of y'all need to learn. And sir has very clearly, given you excellent theory pointers. Plus, it comes with experience. But and remember how many number of procedures these children go through. So you have to treat them with a lot of empathy. Don't take it for granted. Don't take it as usual. कि अरे यार पड़े ही रहते हैं infection के cases in the ward. Things like that. Maybe you can stop the recording and then we can whatever questions we have.